One of the most important questions in patients refractory to immunotherapy is how we are going to sequence therapies beyond chemotherapy. And that remains one of the highest unmet needs in the setting of non-small cell lung cancer.
The therapeutic landscape, again, has been altered by the initiation and elevation of checkpoint inhibitors in the frontline setting. If a patient with 50% or higher expression level gets pembrolizumab and then ultimately has disease progression, we can initiate standard frontline chemotherapy in that individual. And that person, particularly since they have non-squamous, non-small cell, will most likely get a combination of carboplatin and pemetrexed with or without bevacizumab. Then, if they have further progression, further disease progression, we still have an opening for taxanes or docetaxel plus ramucirumab. In the group that I am starting to treat with the triplet combination, independent of PD-L1 level, it's going to be a lot more problematic because we'll have already given both the checkpoint inhibitor and chemotherapy up front. I anticipate, however, that there will be a fairly large cohort that will have been on maintenance therapy with pemetrexed and pembrolizumab probably together, who may be having disease progression at a year or 18 months. So the standard approach in that group has not really been established. These individuals are still potentially sensitive to carboplatin. They've been off carbo for 6, 8, 10 months. They've never seen a taxane, and they've never had exposure to an angiogenesis inhibitor. So I can easily envision putting those individuals on platinum again, carboplatin, with taxane, either weekly paclitaxel or weekly nab-pac, combined with bevacizumab. If disease progression occurs quickly on the PEM-carbo-pembro combination, then I'd imagine I'd be using docetaxel and ramucirumab. But again, the therapeutic approach, our therapeutic standards, will be turned around a bit by the arrival of these agents in the frontline setting. Giving immunotherapy sequentially, I think, is going to be very problematic. I doubt we will see much activity for a switch from PD-1 inhibitor to PD-L1 inhibitor in the face of progression on the original agent. I do have a certain basic comfort level and equipoise for looking at new IO combinations in that group. So if an individual has already received chemotherapy and they've had disease progression, then they've gone on to second-line PD-1 or PD-L1 inhibitor, and at least have had some benefit for some period. Maybe they've been on it for 6 months or 8 months, and then have disease progression. I could easily see assigning that patient to a different PD-1 or PD-L1 inhibitor in combination with another agent. And there are a number of examples in that regard. Certainly CTLA-4 inhibitors are being looked at in this setting, IDO inhibitors, epacadostat being looked at, and some of the results, at least some of the preliminary early results, look quite exciting. I would not make a one-for-one switch, though, from PD-1 to a PD-L1 inhibitor.